Hello, this is Lou Garrison again with part 2 of week 9 on health technology assessment. In part 2 we would like to sort of follow up with some examples in low and middle income countries of some of the challenges and issues involved in implementing health technology assessment. Again, in this segment we'll be talking about HTA in low and middle income countries, but I will begin with just some comments on experience in HTA around the world, and then get into a couple of studies that I was a co-author on, and one of which was in conjunction with Professor Baba Jamira, looking at HTA challenges in low and middle income countries. This slide lays out the key processes that HTA agencies undertake. I would recommend that if you want to do a quick study of a well-functioning HTA agency, I would suggest that you visit the website of the NICE in the United Kingdom, the National Institute for Care Excellence, or I think it's probably Health and Care Excellence now. The acronym has stayed the same, but the name has changed over the years. In any case, NICE is a great example. It takes out a range of functions and processes. Originally it focused on medicines, but has moved on to consider devices and most recently diagnostics. But for any of these technologies, there's before a review begins, there's a scoping exercise to identify the products that would require assessment. Then looking among those, there needs to be a decision made about which ones are prioritized. Then what they call assessment, the manufacturers can submit evidence, the organization, NICE, undertakes, or other agencies undertake a systematic review. And then appraisal is when the decision-making committee considers the evidence from the assessment. It's a deliberative process involving many stakeholders and making a recommendation about coverage and reimbursement, or what you could call funding and implementation. And then there's the actual decision by the budget holder or the patient, if they're going to, or the doctor, or they're going to use the technology. So, and I guess the HTA process is, are funds going to be provided by the budget holder? So, all systems essentially do a better or worse job of carrying out these processes. But it's important clearly to think through capabilities to do all of these in order to do a comprehensive HTA. On this slide, I would like to reiterate a few of the messages from the previous section, part 1. HTA is not new. I mentioned that it had been around for 30 years in the U.S. at least, and the history is an evolutionary one with some advances and some steps backward at times. It is globalized. It's being applied more and more countries, and the number of competent practitioners is growing. For example, I'm a member of the International Society for Pharmacoeconomics and Outcomes Research. It's called ISPOR. We've grown in 20 years to over 10,000 members in nearly 10,000 members in 114 countries. How HTA is used varies markedly, and I like to emphasize that economics is about incentives, and how the information will be used depends on the incentives in the healthcare system for which this is being developed. Finally, it operates in a political sphere. Its role and performance in any country will depend on how it's institutionalized, what independence it has, and what kind of interaction it has with this political sphere. I also would like to reiterate on this slide that if we think of HTA as a technology, in a sense it becomes an economic good, and we can ask the question: are we being efficient in its production? Are we obtaining technical efficiency in terms of the maximum output for the resources used? I've also mentioned that it's a public good. Anyone's use doesn't use it up. It's a global public good. And so one can also ask the question, is it economically efficient? Which is, is it being produced in any system in the efficient way with the right mix of analysts and so on, and stakeholders' involvement, and are they doing the right number of assessments? Now, public goods, if you've taken some basic economics, create an incentive to be a free rider. Since I benefit from public goods, I'm quite happy if someone else provides them. So that's a basic problem, which means that, according to economic theory, that these will be undersupplied by private markets. Hence, we have incentives like patent protection and subsidies to incentivize, to motivate the production of public goods that would be undersupplied by a marketplace. Here are just a few observations on the principle versus practice of HTA around the world. As we said, in theory, it's about all technologies, not just pharmaceuticals. In practice, that's where most systems start, looking at medicines, and we can think about the reasons. As I've said, I will talk about they're relatively few in number. They can have a big budget impact, affect a lot of patients, and they're kind of on the incremental or innovative margin of the healthcare system. In theory, it's also about benefits and costs. In practice, the focus is often on costs and cost effectiveness, and especially budget impact, rather than say cost effectiveness per se. And then finally, in theory, HTA would be a scientific approach, a deliberative process to resource allocation. In practice, it's often about politics. So those are just some words to the wise there about some of the realities of HTA. For the remainder of this part 2, I'll be talking about 2 reports, and I was a co-author on each of them. One of them was with the Office of Health Economics in London, and I would highly recommend that you take a look at their website. They have a lot of good free material. I did a sabbatical there a couple of years ago, and then there's a kind of a follow-on study that Professor Bobby Gamera and I did with some colleagues at University of Washington through our relationship with MSH, Management Sciences for Health. The OHE report was really looking at the factors that would affect the emergence of HTA in what you can call emerging markets or low and middle income countries. And so I think some of the most of this may be fairly obvious after you've thought about it, but there's in reviewing the literature where there's a nice article by Batista and Hodge that noted that you could imagine that once that HTA could occur as kind of an ideas transfer from academics and policy practitioners in more developed healthcare systems, and can sort of be introduced into a market that's not ready for that. So that can certainly happen. Again, as I said, the early interest is to look at expensive technologies like devices and drugs, and maybe devices first because healthcare systems face decisions about adopting high-cost imaging equipment, and this was kind of usually a technological review. An HTA was taken at a kind of a health system level because these high-cost technologies threaten the financial sustainability of emerging insurance systems. But in some ways, the real concern is controlling costs, and that has to do with financial sustainability. So, a long way of saying that it's not necessarily obvious that HTA will be used in the appropriate way in any given system. So you need to think about how to optimize the role. In the OHE report, and in a lot of this thinking, we're kind of asking the question, where does HTA fit into a healthcare system at different stages of development? And as you probably know, many healthcare systems these days are being at least pushed or motivated to try to achieve universal health coverage, which provides financial risk protection for and health services for the entire population. And one question is, where does HTA fit into that? And one way to think about this is, well, recognize that health systems are at different levels, and we broke it into 2 dimensions in the OHE report. The level of spend that's available, what quantity of resources are available, do they have low amount per capita, and so on. And to what extent is the system centralized? How are systems about decisions about healthcare being made? If it's all out-of-pocket spending, and that would be true in many low-income countries, then there's not necessarily any collective institution to really to think about adopting HTA or making these. And whether there's active third-party purchasing of services from providers is also reflects the degree of centralization. So from health system level, these are two key attributes to think about. Next, this slide shows kind of two dimensions of HTA system typology that we thought about. And it was really about what is the focus of the HTA, what is the appraisal, and we defined that earlier, concerned with. Is it about efficacy and safety, as you would see in a regulatory agency? Is it about relative effectiveness? Is it about cost effectiveness, or is it about broader issues, equity, severity of disease, and so on? And then, so what's the focus of the kind of metric? And then there's the question of what's the breadth? What services are being appraised? Is it basic preventative services? Is it new technologies like drugs and devices, and so on? So those are both dimensions that the HTA in a given society can vary upon. This slide brings together the broader conceptual model that shows the relationship between the level of spend, the degree of centralization, the focus of HTA, and the breadth. So it's the interaction of these four factors that essentially determine what bundles of services and service delivery will be considered. The existing regulatory and reimbursement mechanisms will essentially affect the outcome of the health technology assessment in terms of its impact on the healthcare system. So this is just the broad conceptual model that we were working with in thinking about the evolution of HTA in emerging markets. The OHE report, and I don't necessarily expect you to read it, but it is available to you. You might want to read the executive summary. It really is a mix of some theoretical conceptual thinking and just some observations on some case studies. I think there we did Brazil, Taiwan, and China to sort of study what they were doing. And several issues became apparent to us, and this reiterates some of the points I made. So as the system is evolving, you expect third-party funding to develop. And so whoever controls those funds want to make sure they're being used efficiently. HTA can be seen as a tool to do this. It also provides a tool to actively manage some of the providers. However, as I said previously, the initial concern may be more about costs rather than achieving value for money. So it can just be just kind of a budget impact control mechanism. In some ways, to users, it can be seen people are submitting information, just kind of a black box into which you submit your request for funding, and it certainly can be implemented without a lot of thought to appropriate processes to make sure that the stakeholders are involved. Again, if you'll review what NICE's process is, you'll see that they have developed and refined their stakeholder deliberative process over the years, since 1999 when they started. But if HTA can be a product, can be being produced, but it may not. It certainly may not be useful if there's no customer for it, if there's no way to use the results of the decision. So it's important to keep that in mind. Again, this next slide lists some of the issues or some of the pitfalls that implementing HTA in emerging markets or low and middle income countries can face. There needs to be a distinction between the role of the government's stewardship of the healthcare system and its role as regulator of providers and payers and others operating within the system. So the government can be kind of conflicted in its various roles. It's important to try to draw upon clinical practice guidelines in managing chronic disease, and certainly some processes may not be set up to ignore that if they're just focusing on cost effectiveness analysis of single technologies. Again, a lot of times these HTA agencies start with micro level technologies and don't necessarily get the macro level aspects of the system, the health system, the financial underpinnings in order, and the incentives for physicians to provide care. So in understanding how physicians are paid, and particularly in respect to medicines, we talk about the cases of Taiwan and China where a large part of physician compensation can be from prescribing medicines, and that obviously creates some what you might call distortions, or at least incentives that will drive the system in a way that may not be optimal. In the next 5 slides, I would like to move rather quickly through 5 observations coming out of our OHE report. I won't read each of these in detail, but want to just give you the general idea. So, observation 1, we know that incomes are growing, and this is creating demands for universal health coverage and improved health care. And the ability to fund these and supply health care in the short term is likely to be outpaced. So in these situations, you can imagine that HTA would have a role to help reconcile this mismatch between demand and resources. So that's does have a potential role in these situations, even though historically the evolution has been a bit slower. Observation 2 just reiterates the point that HTA of individual technologies is not a substitute for a well-structured healthcare system, and that basically HTA needs to be tied to the macro level system and aligned with incentives at the macro level. Observation 3 is that HTA is not likely to be a one-size-fits-all kind of technology. It really is contextual, depends on the system it's being implemented in. The value of new medicines, for example, varies depending on local circumstances, and the costs for delivering care vary. So, and it's not always going to be a perfect match between cost and value for the other inputs, what economists call a second best world. So these processes are going to fit into an imperfect world, and some flexibility will be needed in their application. Observation 4 has to do with the linkage between HTA and pricing, or what you might call coverage and reimbursement, that we mentioned as one of the key roles of HTA. So these two things need to work together, and basically, if the reimbursement levels, for example, ignore what providers actually have to pay for new medicines, then this is going to underestimate the real-world cost effectiveness. And we see in places like Taiwan, we do see a disconnect between what the government reimburses and what the hospitals, the prices they negotiate with manufacturers. And this may be okay, but it just speaks to the need to analyze how the pricing and HTA regulations interact in a healthcare system. And the final observation, observation 5, is there's no single prescription for HTA methods or processes which will improve societal welfare in all contexts, in all systems. Health systems are going to vary in the value they place on different goals, from equity to efficiency to cost containment, patient choice. Each one is on a slightly different development trajectory, and the way that HTA evolves will be a reaction to the possibilities and pressures and the technologies that the new technologies present at any point in time. And so the relevance and positioning and evolution is going to depend on the development stage and structure of the healthcare system. Next, I want to briefly discuss the follow-on study that Professor Baba Gamir and I did with colleagues in conjunction with Management Sciences for Health. There were 2 components. One was a survey of countries, or a broad survey, and then some in-depth case studies of Kenya, South Africa, and Vietnam. Don't have time given the constraints of these sessions to go into those in depth, but I will say a bit about Kenya as an example. This slide shows the countries that we surveyed, and the respondents were in red, and we'll speak a little generally about the general findings based on that. This slide summarizes some sort of key findings from our survey results, and just to emphasize a few things, you can see, looking at the 5th column, you can see that only a few of the countries we surveyed have a written guideline or process for HTA. And then I'm familiar with South Africa and Namibia. Namibia is at a much earlier stage, and South Africa has a guideline, but still in the implementation phase. In general, they don't. HTA is not well established in these countries. And interestingly, however, there is a rough correlation between the level of government effectiveness and whether they have an HTA process in place. So, lots of scope for improvement here. Next, I just want to offer a few qualitative results about the challenges that establishing HTA in these countries represent. Clearly a need for consensus building among the stakeholders to get things kicked off. And I think although there's rising awareness, currently there's no impetus or strong impetus for the initiation of HTA. One of the issues is obviously the lack of capacity in terms of analysts and the human resources needed. And then there's also important processes in defining the legal requirements and responsibilities that would need to be available to enforce the use of HTA. As I mentioned, we reviewed 3 countries in depth that had case studies for this project: Kenya, South Africa, and Vietnam. South Africa has pharmacoeconomic guidelines in place, and Professor Bobby Gamira and I have done a workshop there to sort of work on training the staff and the agency. But it's still at a very early stage of development and adoption in South Africa. Vietnam is a very decentralized place, and it doesn't really have a centralized authority, and so it's whatever's being done is being done informally at a hospital level. I just wanted to maybe say a bit more about Kenya. We have a couple of slides here. First, there is no national HTA program. The National Regulatory Agency, the Pharmacy and Poisons Board, does review things in terms of benefit risk, and there is a Drug and Therapeutics Committee that does look at the EML, but is not formally using HTA methods. The case of Kenya serves to underscore the qualitative observations that I made a couple of slides ago. Again, the issues are resource constraints in terms of funding capabilities, lacking the trained health workforce to do the analyses, and some of the stakeholders that we talked with think that the limited regulatory capacity and the lack of well-trained pharmacists are a barrier to the efficient use of medicines. At the same time, we talked with people who'd heard of HTA. There was an interest in this, and we got the general perception that it's going to play a more significant role in the future as the health system moves to more towards universal health coverage. There was a major devolution of governmental authority in Kenya since we did this survey, so it would be interesting to follow up to see how that has affected perceptions there. I would like to end this part with 2 more slides just to reiterate some of the key points. Again, the use of HTA in the countries that we surveyed is extremely limited at this point. Other than broad health system reform evaluations, macro-level HTA, and we can say that certainly a number of systems are looking at implementing universal health coverage, which is a kind of macro-level HTA. Other than that, most of HTA tends to focus on medicines and guidelines for their use rather than other types of technologies. Limitations on the number of trained professionals to carry out these studies as a constraint in virtually all systems. At the same time, we shouldn't oversell micro-level HTA, and we need to recognize that it sort of may not make sense in a system that doesn't have aligned insurance and provider incentives. Finally, I would like to offer some observations that cuts across HTA in both low and middle income countries and in other systems. Key point is that the impact of the HTA and in particular cost effectiveness information in a system is going to depend on the incentives of the providers, insurers, patients, and others to act on that information. If HTA is going to be a scientific exercise that contributes to decision making, it's important to insulate that process from political influence, or at least have a workable system of checks and balances. Of course, any agency still needs to be responsible and accountable. HTA is resource intensive, and while it's appropriate to focus on to do micro level HTA, it's important to keep in mind that the macro level HTA sets the context as it important for micro level HTA to be effective. And then I think, as from an economic perspective, we always want to ask the question, what would be efficient health technology assessment, both from a country's perspective and globally, given the global goods, public goods nature of health technology assessment. And I think we like to emphasize the static perspective of trying to maximize qualities and benefit and value out of the short-term perspective. But we also need to keep in mind the long-term perspective, dynamic perspective, which is really about eliciting the optimal amount of innovation. And that's what we'll turn to in Part 3, talking about incentives for dynamic efficiency. So Part 3 will be on drug development, innovation, and value. And we'll talk about the role that the assessment of value, and the main tool we have for that is cost effectiveness analysis and the ICER that you've talked about, and how that's related to incentives for innovation and even broader concepts of value that I would like to bring out. So that'll be in Part 3 of Week 9. Thank you.